A 65-year-old male on warfarin anticoagulation presents with acute chest pain, progressive dyspnea, and hypotension. I am showing you a frontal chest radiograph and an axial chest computed tomography scan. Describe the findings.
The frontal chest radiograph demonstrates complete opacification of one hemithorax with marked widening of the intercostal spaces. Crucially, the trachea and cardiac silhouette are shifted contralaterally, away from the opaque hemithorax, indicating a massive space occupying pleural process. The axial contrast enhanced chest computed tomography scan confirms a massive, high-attenuation pleural fluid collection causing complete compressive atelectasis of the adjacent lung parenchyma, which appears as a compressed crescent wrapped around the medial aspect of the collection.
State your primary diagnosis and the clinical relevance of the high attenuation collection in this patient.
The primary diagnosis is a massive hemothorax. Given the history of warfarin anticoagulation, the high attenuation of the pleural collection on computed tomography represents acute blood, which exerts a significant mass effect on the mediastinum, leading to compression of the superior vena cava and heart, explaining the patient's hypotension.
What is the differential diagnosis for a complete whiteout of a hemithorax on a frontal chest radiograph?
The differentials include a massive pleural effusion or hemithorax, complete lung atelectasis, massive lobar pneumonia, and a prior pneumonectomy.
Explain how to differentiate a massive pleural effusion or hemothorax from complete lung atelectasis on a chest radiograph.
The key differentiating feature is the position of the mediastinum. A massive pleural effusion or hemothorax acts as a space-occupying lesion and shifts the mediastinum and trachea contralaterally, away from the opacified side, with widening of intercostal spaces. Complete lung atelectasis represents severe volume loss and pulls the mediastinum and trachea ipsilaterally toward the opacified side, with rib crowding and hemodiaphragmatic elevation.
Describe the bronchial cutoff sign on chest radiographs and its clinical significance.
The bronchial cutoff sign is the abrupt termination of a central mainstem or lobar bronchus air column, often showing a straight or convex border. This sign is highly suggestive of an endobronchial tumor obstructing the bronchus, leading to complete lung collapse.
What are the common endobronchial tumors that can cause complete lung collapse?
The most common causes are bronchogenic carcinoma, carcinoid tumors, bronchial hamartomas, adenoid cystic carcinoma, mucoepidermoid carcinoma, and endobronchial metastases.
Name several causes of a non-traumatic hemothorax.
Non-traumatic causes include therapeutic anticoagulation, vascular malformations, pleural metastasis or primary angiosarcoma, catamenial hemothorax from thoracic endometriosis, and ruptured thoracic aortic aneurysms.
What is the primary treatment for an acute massive hemothorax?
The primary treatment is the immediate insertion of a large bore chest tube, typically 28 to 36 French, to evacuate the blood, relieve the mass effect, allow lung ray expansion, and monitor ongoing blood loss.
State the specific surgical thoracotomy indications based on chest tube output.
An urgent surgical thoracotomy or video-assisted thoracoscopic surgery is indicated if there is an immediate output of 1,500 milliliters or more of blood upon initial tube insertion, or if there is ongoing output of 200 milliliters or more per hour for 2 to 4 consecutive hours, or if there is persistent hemodynamic instability.
What long-term complication can arise if a hemothorax is incompletely evacuated?
Incomplete evacuation can lead to organization and scarring of the retained blood, resulting in a fibrothorax. This forms a thick pleural peel that restricts lung expansion, necessitating a surgical decortication. I would immediately contact the cardiothoracic and trauma surgery teams for emergency chest tube placement and hemodynamic stabilization. Refer to cardiothoracic surgery.